Welcome back to the podcast. I'm your host, Dr. Sammy Clilly. Now, things look a little different this season. That's because we're here with a new desk. Believe it or not, we've made it. We have a desk now. Welcome to Season 2. New setup, but with the same great conversations. I'm so excited for today's podcast because today I'm joined by Dr. Michael Brandt, a facial plastic and reconstructive surgeon based in Toronto, Canada. Dr. Brandt is an assistant professor in the Department of Otolaryngology and Head and Neck Surgery at the University of Toronto and an adjunct professor at the University of Western Ontario, otherwise known now as Western University. He is nationally and internationally known and lectures all over on advanced topics in facial plastic surgery, including cosmetic injectables, as well as cosmetic and reconstructive facial procedures. I'm really excited to talk about all these things. Dr. Brandt's practice is exclusively focused on facial plastics and reconstructive surgery at Form, Face, and Body in Toronto, Canada. So without further ado, let's get into it. I cannot express how awesome it is to have you here today. It is truly like an honor for me. You know, many of the people here don't know that we've known each other for a long time. And the first time I met you, I might have been a medical student, I think.
I think so.
I think I was. And then I was very fortunate to be your R1 when you were an R5. Now, R1 meaning first-year resident when Dr. Brandt was about to graduate. But I'm going to call you Mike.
Was it really like a 5-1 split?
I think so.
I don't know.
I think so.
Maybe, yeah. You were... Who else was in your year?
It was me, Susan Tan, and Brandon Wickens.
Okay, yes.
Yeah.
Yeah. Because for some reason I peg you in with the other Newfoundlanders.
Well, there was a few of us because there was Doug and JP the year ahead.
Right.
And it happened to be that around that time. But I was very fortunate that you and I got to be placed together for a long period of time. Particularly, I think it was at St. Joe's.
Okay.
And that's where we got to kind of hang out a lot. And then I've been very, watching your career, evolve as time went on, and you were a big influence on the things I chose for sure.
Well, as I said earlier, I'm no chief, and here I am with the chief. I'm really excited for where your career has gone and the trajectory, and how you just keep evolving yourself and building. It's fantastic. It's great to see.
Well, I had great mentors like yourself. That's the wonderful thing. And how we often kind of have these conversations here is more we start. So that the audience kind of knows, like, how did you get into this space? Like, where did this begin with you? And like, even start at the beginning. Like, did you always know you wanted to go into medicine? I've talked about this with many other people, and everyone has kind of a very different kind of trajectory. Some people, they knew right from the get-go. They had family that was involved, things like that. Others just serendipitously fell into a whole series of circumstances that said, this is where I want to go. How was it for you? I don't know if we ever had this conversation, that part.
I don't think we have, but, I'm Jewish, so it was either doctor, lawyer, or accountant, right? That's just sort of the basics. But no, the reality was my grandfather was a family doctor, and he lived in Israel, and every time I would visit, which I did a lot when I was a kid growing up, basically spend my summers there, that I would see him run his clinic and all that, and I was kind of intrigued, like, what are you doing in there? And I thought it was kind of cool. So as I got a little older, I asked some questions and piqued my interest. And then actually in high school, I did a co-op where I got to go to Mount Sinai Hospital in Toronto, spend some time in the ER and with thoracic surgery of all sort of surgical disciplines.
Wow.
And I thought surgery was where it was at. I thought this is the coolest thing ever because I've always sort of been mechanical and technical. And I thought, wow, you get to like fix things physically. It's pretty spectacular. What an honor. So that was sort of the initial interest. And then, the whole med school application and all that process came in. And then in med school, I sort of still had that interest in surgery. I spent time with a variety of people, including several of the thoracic surgeons that we know well, having spent some time on thoracics.
Yes, we do.
At that point, I sort of decided that maybe thoracics really wasn't for me. It was sort of a different sort of specialty, huge commitment relative to your patients and hospital and everything else. And I was really looking for a bit more balance at the time. And I had a shared mentor, Jason Franklin, who I had known since I was in high school. And he said, well, why don't you just come check out ENT? I checked it out. And for some weird sort of amazing alignment of the stars, he sort of set me up to work with Corey Moore.
And that's how it happened.
And that's how it happened.
Oh, wow.
And Corey Moore is a facial plastic surgeon. And that was back when he was still doing trauma and all this other stuff. And I'm like, this is the coolest specialty ever. And really that started everything. And then, thankfully Corey sort of took me under his wing, and really great mentor. And I sort of did the whole ENT thing, went down the track of facial plastic surgery, and here I am today.
Yeah, no, I mean, I'm obviously biased because I came from the same pedigree as yourself, but you were phenomenally trained, and then you were one of the few people who got selected to go to do Shan Baker's fellowship in. Well, I guess he's retired now. He must be right now. Yeah,
he is.
But he was at the University of Michigan, if I'm not mistaken.
That's right.
And for those who definitely don't know, Shan Baker is one of the textbook writers, one of the godfathers of all facial reconstruction when it comes to skin cancer and how to how to rotate tissue into the right space and what that looks like, and using geometry in ways that I guess people hadn't really thought about before. And you came and brought that skill set back home to Canada and everything else, and then expanded and blossomed beyond that point afterwards.
Yeah, no, Shan was an incredible mentor. I caught him really sort of at the tail end of his career, in the sense that he's a smart guy in a variety of different ways. But one way in which he's smart, he wasn't one of these guys who sort of just stuck around to stick around forever. He sort of got out while he was still healthy, and he's still, hiking and doing all kinds of amazing things that he truly loves. But I caught him towards the tail end of his career, where really he had sort of refined everything, had a rationale behind every single thing you would do. And he was the type of guy where you'd ask him a question and he wouldn't answer you right away. He'd sit there thinking for a few minutes, and then he would give you this sort of like textbook incredible answer full of anecdotes and sort of his sort of culmination of experience and everything else to get to why it is the way it is, and why he does things the way he does. And it was so special to be able to really learn from that. And he was just a great guy to spend a full year with, and really learn everything that he had to offer. And Michigan is just a great place to be.
Yeah, no, I remember when you went there, I was very envious, and because it just seeing what he was doing, and I think because of you, he came to visit us for one lecture when we were when we were residents. And of course, somehow I got positioned to be the guy to drive him from the airport.
Right.
And so he was very, very kind, very, very nice. And I said, "What? This would be a lot of fun to hang out with this guy for the next, I don't know how long you were there, a year or two or whatever it was."
It was just a year.
But yeah, that was fantastic. So then, since then, you went back to Toronto, where home is, the family is, and created the empire that is Form, Face, and Body now.
Well, so yeah, Form was an evolution. So when I came back, there was a whole series of challenges relative, within the Canadian healthcare system. A lot of challenges relative to
fully familiar with those, yeah.
OR time and availability and all these things, and trying to get a foothold on work. And I started off doing some general ENT, but I also started working with a few dermatology groups, which was really great. I got to practice all those sort of skin cancer reconstructive procedures and techniques that I had learned with Shan Baker. So I sort of continued on that path while sort of searching for a job for a really long time, and worked in a variety of settings, and then ended up meeting my current colleagues and partners at Form, Face, and Body. And that's been a very sort of natural progression of career. And these guys are a great group of guys, and we're really building some special things at this point in Toronto relative to cosmetics, as well as sort of longevity and health within sort of one of the best parts of the city is really where we're building currently.
Yeah. I mean, you and I, we've talked about this before. I remember talking about this when we were residents, but the desire to help people age gracefully is something that is very, I believe, to be very noble, because there's a lot of people that want to continue to feel and look the way that they feel. And I commend you for doing that, because that's very different than vanity. It's it's one of those things that people themselves, it goes a lot of ways to the core of their self-esteem, right? So you really attribute or contribute a lot to that in people.
Thanks, Sammy. And really, it's a unique subspecialty within our collective field where you really get an opportunity to do a variety of cool things that really are so impactful on people's lives. Where they may have a skin cancer, you're removing that, you're trying to rebuild it and camouflage it to the point where nobody can tell that they've had anything done, and that's a unique privilege. And then fixing scars on people's faces. I mean, we all do that as part of our decision making when we're designing surgery and thinking about surgery within the head and neck. But within facial plastics, that's a every single day sort of thing. And then really, patients come in and they're dissatisfied with a certain thing that's really impactful to their life and how they feel and their ability to interact within the workplace or seek out and pursue love and all these other sort of things that are core to their person. And you're really able to help them with that. And it's really sort of the balance of form and function that we're able to contribute to.
You got the right person at the helm for that. So in terms of your team and your group, is it just, are you the only facial plastics person in terms of like ENT surgical trained, or do you work with a whole multidisciplinary team that kind of helps with that?
So I'm the only, within our group, I'm lucky to work with a couple of plastic surgeons, Ron Samoji and Corey Goldberg, as well as currently Wakas Jalil. They're all full body plastic surgeons. They have their areas of interest. I'm the only facial plastic surgeon within the group. So we all sort of have our niche area of expertise where we're really able to bring that all together and cater to sort of every part of a person and really sort of balance that amongst our group. And as we expand into our new facility that we're building, over 20,000 square feet in Toronto with operating rooms and longevity medicine and everything else, we're really going to be able to integrate so much more into providing patients with absolutely a world-class experience that they're not able to get anywhere else.
That's awesome, buddy. So now, in terms of, all the things that you've been doing, and I've been following your career for a while, I've really been impressed with all the stuff you've done with like hair restoration and whatnot, because that's a skill set I was never taught. I don't think you were taught when we were going through either in that way. And it's something you've definitely acquired over time. And then of course you add that to the number of people I've run into and people around me that are, they're flying God knows where for hair transplants and, all those types of things, and comedians making jokes about it and this.
Right.
So it's become a bigger thing. And I want to learn, like, A, how that evolved for you, and then B, what exactly goes into it? What happens? Tell us a little bit more about it, because it still seems a little bit voodoo-ish to me.
Yeah. Hair restoration is this incredible thing where, if you're into gardening, you're into that analogy. We're able to take, an existing forest of trees at the back of your head and basically redistribute them to a new location and have them grow elsewhere, which in and of itself, honestly, is like magic. It's so cool. It is like magic. And I got into it through some colleagues. They were doing it in their practice and sort of observation and seeing how they do it. And it involves sort of a multi-person team in order to really deliver on that. You need people to harvest grafts. You need, people to assist you with that. You need people to design the hairline myself and take the patient through the entire journey. And then you need people to plant the grafts themselves. And the experience is a full day affair. This is not sort of a simple operation. This is a meticulous procedure that lasts like 12 hours plus sometimes, depending on the number of grafts that we're transplanting to really help people out. But there's a variety of different techniques to do hair transplantation. The current gold standard is FUE, follicular unit extraction. That's where we harvest each individual follicle one by one by one in order to transplant them into their new location.
So basically planting one tree at a time.
Correct.
Wow, okay.
Correct. So that's why it takes so long.
So then the other question I had is, because it's so tiny, each of these follicles, is this being done manually or is it being done robotically?
So we are very fortunate and one of the only clinics in Canada to have acquired the Artist robot. So the Artist robot helps look at each individual follicle 60 times per second and helps us harvest those follicles. So you can imagine somebody doing this manually. They're extracting, 2,000 follicles or more in a given setting. The first follicle may be better than the last follicle that they're harvesting because they're bringing in all their baggage and everything else. The nice thing is the robot doesn't have baggage. It didn't have a late night. It didn't have kids that woke up. It doesn't really care. It's harvesting the best follicles all the time. So we're very lucky to have that technology within our practice, where we're really able to harvest the best quality follicles. And then, better quality follicles lead to better quality results at the end of the day. And that's really what we're trying to provide to our patients.
So where are they typically harvesting the follicles from? Like, are other parts of your arms, your back, or like,
that'd be pretty amazing, right?
Yeah,
because the hair's been running down my back, off my head for the longest time. So relative to where we're harvesting from. So, I like to joke around and call it the Dr. Phil area.
Okay.
So the Dr. Phil area, all those hairs that exist on Dr. Phil's head, those are all permanent hairs. The rest of your hairs on your head are going through this gradual gradual death phase, basically. And that's primarily hormonally driven. But the caveat is everybody's making this hormone.
Yep.
It's a subspecial or a subderivation of testosterone called dihydrotestosterone. It's a byproduct of that production. So some people are really sensitive to DHT. Case in point. Other people are less sensitive to DHT. Case in point. So we're both making the sauce. And in fact, I'm taking extra sauce. I'm taking extra testosterone. I had testicular cancer. I'm taking extra testosterone. And it doesn't matter how many meds I take to block that testosterone. It's still going through it. Which is why bodybuilders have no hair, or they have a full head of hair. There's nothing in between. They're either really sensitive to it or they're not. So the good news is that Dr. Phil horseshoe of hair is insensitive in everybody to DHT.
Okay.
And we really, use that to help us transplant those insensitive hairs into a new location. And that ends up being permanent hair in the new location.
What I want to understand now is, take me through the journey that a person has to go through when they've kind of come to the decision that they want to do something about this. So I'm a young individual, man, or woman, but quite often I presume the majority of these cases would be males. And I kind of said, you know what, I identify with having hair and I have a problem with this. Where do they go to first? Like, what's the first sequence of events that eventually gets them to the right hands?
So for a lot of them, they're jumping on Turkish hairlines and they're flying. No, that's not the right answer. So the right answer is to really seek out a medical professional, first and foremost, and somebody who has a background and knowledge relative to hair. And there's a variety of different individuals with that specialty and interest. Either you can't see a specific hair clinic, you can see dermatologists. There's a variety of specialties that really focus on hair loss and being able to do all the investigations that go along with that. So the first sort of step in that process is determining, why do you have your hair loss? Is it multifactorial? Is it primarily, as we mentioned earlier, hormonally driven? What's the actual cause behind that? And that plays more into sort of women's hair loss as well. Once all that is sort of gone through, then we could try to come up with strategies. So strategies revolve around retaining your current hair is sort of the number one strategy. You want to keep what you have as long as possible. And that's usually focused on medication. So some sort of DHT blocker medication, finasteride or dutasteride. Those medications are oral medications. They were usually used for enlarged prostates. And now we're using less dosage to sort of maintain hair. And basically, that's the medical pathway. There's other ancillary treatments as well.
Are those medical treatments, from your knowledge, typically topical or are they oral?
The oral works better. We don't know the efficacy of the topical. Now, people are working on topical preparations of finasteride, dutasteride, and there are some suggestions that they work, but we don't know 100%. And, people are trying to circumvent any potential systemic side effects from taking these things orally. But, the problem is you have a medical condition. Your medical condition is hair loss.
Right.
Androgenic alopecia, for example, male pattern hair loss is the diagnosis. Just like high blood pressure. To treat that, you take your medications and it will lower your blood pressure or lower your chances of losing more hair, right? So once we've figured out the diagnosis, we apply the medications, for example, just to sort of help with that. And there's other ancillary treatments, whether those topical treatments like minoxidil Rogaine or even, light-based therapies, low-level laser therapies, the red caps and things, they can help a little bit. Platelet-rich plasma therapy, which is really sort of more in the longevity space. But we take your blood, we spin it down, we then inject a portion of that blood back in your scalp. And what that does is forces new blood vessels to grow towards the hair follicles to help sort of move them from that miniaturization death sort of phase of sort of dying up into sort of normal hair again. And that's sort of really the preservation sort of component of hair. But once the trees are dying and the roots are dead, you're not growing a tree back is really the issue.
Right.
So in that instance, really what we need to do is talk more about hair transplantation. And then that's really the next phase of sort of restoring people's confidence with their hair.
Okay. That's great. So, all right. I'm trying to map it all out in my head of all the sequence of events that people would go through. So quite often, and correct me if I'm wrong, they'll go see someone. They'll probably start on something medical first, but also go through a diagnostic pathway to figure out what is happening.
Correct.
And so that individual could be, as you said, someone who specializes in hair, usually a dermatologist, but possibly someone like yourself, a facial plastic surgeon who specializes in this. And then from there, that sequence might take upwards, probably, it sounds like about a year or longer.
Not even.
shorter?
I mean, between blood work and investigations and things like that, it could be relatively short-lived. It just depends on sort of turnaround for some of these things and how quickly, we see patients back. The good news is, I mean, for most guys, about 70 to 80% of male hair loss is androgenic alopecia. So, you're throwing darts at a board, more often than not, you're going to hit. And that's usually the cause. And then there's very sort of defined treatment strategies for that.
And then based on response for most of these medical treatments, before they would say you'd hit failure to move on to restoration, what time frame do they usually give?
It's a great question. Yeah, usually 3 months is the time frame for each of these therapies before you'll see really any response. So if you go out to Costco and you buy your Rogaine, you start putting on your head, you're really not going to see anything for about 3 months. Okay. And really only about 60% of the population does Rogaine actually work for.
Okay.
There's a good portion of the population where it just doesn't absorb, doesn't work properly as well. So, it's hard to say if you're failing or not. You have to give it adequate time really to see an effect. And it's not... Sometimes that effect is not what you're expecting. Some people are expecting, I'm going to put this on, I'm going to be like a chia pet, I'm going to grow a full head of hair, it's going to look amazing. No, we're looking at preserving your hair, really.
Right.
We're looking at maintaining your hair. So it's not about necessarily regrowth and all this, which is sometimes happens, but sometimes it's just about maintaining what you currently have and improving what you have going forward.
Okay. All right. That's a wealth of knowledge that I had not gained up until this conversation. Not largely because I haven't dealt with that patient population before, but that's really, really interesting. And I know that a lot of people in the community here definitely have an interest in knowing about this and what to do and whether they should pursue this or not. And from everything I've learned with you and others before having this conversation today, if it's something that truly bothers you, you don't have to suffer with that. It's something you can absolutely do something about. And there is a treatment paradigm to go ahead and help you with that. And it's not tremendously in the world of things of what we would call invasive. It's not terrible, and in most cases, and most people do pretty well. Would that be inaccurate?
Without question. I mean, the first and foremost thing is if you're noticing hair loss, you've already lost a whole bunch. Okay, so most people who've noticed it have already lost 50% of their density of hair before they even start down that investigation pathway. So if you're noticing it, go get some, help, look into it. It will only get worse from here. You have a genetic destiny, and that's typically related to some family members or what have you, and that's really what you're looking at. So the goal is to get treated early, especially if your hair is really important to you, and that speaks both to men and women, and then go down the path. The medications, all of the different treatments are largely benign with very few adverse effects, very few side effects, especially hair transplantation. I mean, it's one of these procedures with really low downside, very low risk, very minimal pain and challenge relative to recovery. It's basically like 3 to 5 days of real recovery. And then it's just sort of having things heal and grow beyond that. So it's a really sort of relatively straightforward procedure to really restore your quality of life.
So let's talk about now, you get to the point of the hair restoration part, the part that I'm sure you like doing more. When that happens, you said the procedure can take upwards of 12 hours, or does it always take around that long? I guess it depends on how much hair.
How many grafts.
Yeah, how many grafts. So considering that you're doing it robotically, is one graft considered one follicle, or is one graft considered like a patch?
A follicle.
One follicle. Wow. Okay.
Yeah.
So you're basically playing just Tetris, moving them around in different places.
100%.
Okay, all the way around the head.
Yeah.
Is there a strategy of how you map that out?
There is. So there's a strategy relative to the donor area.
Okay.
So we don't want to over harvest the donor area. You don't want to look like you've been strip mined at the back of your head.
Right.
You don't want to make it obvious, which is really the old way of doing hair transplantation. You see that big smiley face cut at the back of people's heads. And you're like, they had a hair transplant.
Right.
Or now what we're seeing is that at the front of their head with the Turkish hairline, right?
That's
the
right.
straight line across their head,
that's right.
which looks absolutely bizarre, especially as they get older.
That's right.
So yes, we do map out the donor area. We try and be sort of meticulous in how we plan that.
Right.
We do map out the recipient site, where the new hairs are going. And we want to make that not only look great today, but we want to future-proof that as well.
Okay.
We want to make it so that as you get older, you're not going to have a bizarre hairline. We got to keep things age appropriate. And we're also playing with numbers, right? Like you have a bank account of only certain number of dollars relative to the number of follicles you have to donate. And you've got a big area that sometimes needs to be covered. And we have to strategize how best to cover that area, whether we should leave some parts of it sort of bare still, like, at the back, and just focus really at the frontal hairline, for example. Each one of these things are considerations.
So when you're having these conversations with people, how much when you're talking, are you using technology to explain what they're going to see? Or is this something that they, based on your conversation, they're kind of understanding like, oh, this part's going to move a little bit up here, that part's going to move a little bit over here, et cetera?
So we have a number of photos that we go through in an in-depth consultation. We go through, our consultations usually about a half hour or 40 minutes. We go through absolutely everything relative to hair loss and strategies, and we give them all the different options relative to improving things. Frequently, we will draw out sort of where their hairline could be, where we make where we would suggest that it is, as opposed to really pushing the boundaries of aggression relative to hairlines. So each one of these things is part of that sort of overall process when we're chatting with patients.
Wow. Yeah. Okay. Wow. I could go on asking more questions about all of this stuff. Where do you see this technology advancing even further? Is there anything coming down the pipes with stem cell transplantation or gene therapy to reverse some of these genes that may be promoting the hair loss, or anything that that are coming down the pipe maybe potentially? I know theoretically we talk about it, but you're more in the space wondering if that's actually coming.
Yeah, I think it's an amazing time to be in medicine.
Yeah.
There are a variety of different things, technology and otherwise. I mean, yes, there are people working relative to gene therapy to sort of stop the loss, right? And prevent future hair loss, put guys like me out of business eventually, which is great. That's fine. It's kind of like oncology, right? The best treatment for cancer is not going to be surgery.
That's
right.
right.
You're going to get your immunotherapy. You're going to be, taken care of.
That's right.
But, relative to current issues with hair transplantation, the biggest rate limiting step for us is the donor area. How many follicles you have to donate without it looking bizarre, right? And looking at over harvested. So the future is relatively close in the sense that stem cells are being used to grow skin. And if you can grow skin,
you can grow hair.
Grow skin with hair on it. And if you can grow hair, you could potentially harvest those follicles and use them for transplantation. So the next step is to harvest stem cells from an individual, grow a sheet of skin with hair on that skin, harvest that skin harvest that hair, for transplantation. And no longer are you restricted based on your donor area. In fact, you don't even need a donor area. You could just use those stem cell derived follicles and plant them.
That would be really cool to see and watch. It'd be really, really neat.
Yeah. And that's the future. I mean, hopefully we see that within the next 10 years. I think it'd be pretty spectacular.
So now, because my mind is going this way now, in terms of when you do the implantation and you put the grafts in, how many of those follicles hold? Like is it a almost 100% take? Because they're coming from the same person. But if we're using the gardening analogy, you move one plant to another place, that plant doesn't always like it. So I'm just curious to know, is it similar, or is it no, they actually are a bit more resilient?
Question. That's a great question, Sammy. And obviously, you're coming at this from a doctor perspective, having done skin grafts and other things. You know that it's not always, all that it seems. And you're exactly right. So the sort of dark part, the dark secret of hair transplantation is that they don't all survive. And we talk about this during our consultation, and it's not one-to-one. In fact, for most clinics worldwide, it's somewhere in the range between 70 and 85% survival of
Okay.
grafts, which isn't bad.
No.
But if you're talking about these massive, large-scale hair
You're going to
transplants
see
around the world,
30%. Yeah.
you know, they're doing 4,000 grafts.
Yeah.
30% death in 4,000. Not only do those not survive where they've
And
been moved.
Just to be clear, that's death of the graft, not death of the person.
Correct.
Yeah,
Not death of the person, death of the graft. So not only do they die in their new location, but you don't have those to donate in the future, which is a huge problem, right?
Okay.
So really we try to minimize sort of the death rate of these grafts and maximize survivability. So how do we get to maximum survivability is sort of the next question. So one is potentially using the robot to harvest these.
Right.
It can improve that. Using a very experienced team to harvest the grafts, how you take care of the grafts immediately following harvest, how they're implanted, and then using ancillary therapies like hyperbaric oxygen, red light therapy. Each one of these things that we're able to integrate at Form, Face, and Body is really unique to our practice. And really, we're hoping to be able to push that survivability rate to well over 90%.
That'd be awesome.
In the future, so that patients are really getting more value out of their transplant, right? Because at the end of the day, you're spending a chunk of change to get this done.
Yeah.
And you're hoping for a great result. And we're hoping as surgeons who are taking care of these patients that we want to deliver the best quality result too. We want happy patients at the end of the day.
You're the same. I know you're similar to me in that, you know, you're not happy if they're not happy because it's just,
we take this home.
yeah, like it festers in your head. You're wondering, like, why did that happen? What can I do to make that better? Or what can I do to
100%.
solve the problem for them right now? You know, I don't know if there are other disciplines out there that carry that with them so personally, but we as surgeons definitely do carry that a lot.
And it doesn't really matter sort of what step of their surgical journey
Correct.
was a failure, or not necessarily a failure, but an inadequacy or
Or a
something
bump
sort
or
of
whatever.
occurred.
Yeah.
It doesn't matter what phase that is. We take that absolutely personally, which is sort of a very different, like you said, than a lot of other types of jobs where you're like, well, that was, you know, the person working the grocery aisle. And
Yeah.
it wasn't really me involved in that particular
Right.
issue. Whereas it doesn't matter if it was our front end staff or someone else in the operating room or some sort of bump in the road in recovery. It's us at the end of the day. And we want to deliver the best possible care to our patients.
That's right.
Yeah.
Well, this has been really enlightening about hair restoration. I think I can keep going a lot. We should probably almost dedicate a whole episode to this one time. Next time you come down again, we'll do that. But I want to pivot because the other thing that's been new in the last several years that even for me, who does do a lot of functional septal rhinoplasty work, has been this non-surgical rhinoplasty push. And at first, when I kept hearing about it, like, this sounded like, you know, the minimally invasive thyroid stuff that they would talk about, which weren't really that minimally invasive. You'd hear this nonsense all the time. I was thinking that was where this was coming from, but no, I see colleagues that I truly respect and adore all adopting this. I said, okay, what's going on here? So I said, no one better to explain this to me exactly what's going on than you. So what exactly are we talking about when we're talking about when you hear about either liquid rhinoplasty or non-surgical rhinoplasty? What's going on?
So great question. It's one of my personal favorite procedures these days. And really what we're doing is we're using liquid gel, so hyaluronic acid gel, which is filler. So injectable fillers, people know brand names. We don't need to support any particular brand, but there's a variety of these injectable fillers that people are using, you know, or people understand them to be used for wrinkles or for aging faces. And really what we're doing with that liquid is we're injecting it into the nose and we're using it to reshape the nose. So there's sort of tends to be a little bit more of a specific patient population where this works great for, but within that population, you can get effectively a complete change to their appearance in about 15 minutes with minimal downtime. Yes, there are risks related to this procedure. We'll chat more about that, but for the right patient delivered, you know, as safely as possible, it's really a really unique technique that, you know, is amazing. I think it's like magic.
Well, that's really cool to hear. Before I get into the technical stuff about it, I just kind of want to understand why all of a sudden now, because the hyaluronic acids have been around for a long time. It's not like the actual material is new. Is there something new about it, or the way that it's being the delivery profile? Like it's no longer a different kind of gel that they're using with it, or something? Or what changed recently that we didn't know or didn't see 20 years ago, or did someone figure it out how to do it right? Is that what happened?
So it's a combination of things.
Okay.
Like most things in medicine, it's a combination. So I think part of it is the gels have adapted to different viscosity.
Okay.
So there's different thickness of that gel and different lifting power of that gel.
Okay.
So some gels are very thin. We use them in certain areas where you really want a thinner gel that's not going to lift or create lumps and bumps, like around the eyes, for example.
Yep.
You really don't want to use that. Or if you're getting very close to the skin surface, you want to use a thin gel. If you're working in deeper structural changes, then you want a thicker gel, largely to deliver value to the patient. You don't want to be using a ton of this stuff to create the effect. And really, it's kind of like, you could think of it as these hard implants we used to place as residents, where you're putting a hard implant in to lift their cheek or restore certain skeletal features. And you can inject this thick gel that also does the same thing. You place it on bone and it can lift the bone, and it can do these things without spreading and creating all these other problems that you run into with thinner gels. So
Because that was the one thing before. They used to run a bit, right? So you couldn't, wherever you put it, like before, it wouldn't necessarily always be there, I don't know, 2 months later.
Right. It would spread and thin out and get absorbed and all these other things. So these days, a lot of these companies have helped with the absorption rate. So these gels are lasting longer than they ever have. In fact, to some extent, they stick around forever, to be frank with you. Now, they reduce in size, reduce in volume, but they still stick around. So, that's a whole separate discussion we can have relative to filler. But one, they stick around forever. And two, they have this lifting capacity to them that we call G prime. And that's related to how much lifting power that particular gel has. So how much of a resistance to pressure, how much it can lift up. So there's an evolution of the product. And then there was just like in other areas of medicine, crazy people doing crazy things. They're like, hey, why don't I try lifting up this problem in the nose with it? And they did. And they got this amazing change. And one of the people who really, did that in the United States is Alex Rivkin. He's an otolaryngologist, facial plastic surgeon. His entire practice is essentially doing non-surgical rhinoplasty. He's in Beverly Hills, LA. Great guy. He's a friend and colleague. And really sort of he's changed the entire paradigm relative to that. Largest case series talks about, and he publishes relative to risks and all these things as well to really sort of put a scientific sort of backing and component to that, some objectivity. And really, he sort of pushed a lot of this forward, and other surgeons and providers started doing this. Pros and cons relative to a variety of different people doing it, because there are risks associated with the procedure.
Well, I mean, I think that's like any surgical procedure that you put out there. The person who first pioneered it, the next person who does it, or the fifth or sixth iteration of that person, isn't going to be doing it the exact same as the first person. But as long as you created something that, for the most part, like a good 90% of the time, it is doing exactly what you're expecting it to do, then you've done the right thing, I think, personally. So it sounds like that's what's happened here, which is great.
That has. I mean, there's still defined risks, even with sort of the most experienced providers. With any filler, there's the potential to inject that into a blood vessel. If that happens, it blocks the plumbing. If it blocks the plumbing, that blood can't get to where it's supposed to go. You can get all sorts of problems that really focus on that issue. You can get blindness. You can get, skin death. You can get all sorts of stuff that can happen theoretically with these fillers. Thankfully, there are techniques and other things we can do to minimize those risks slightly, but those risks still exist, especially, especially in those patients who've had previous rhinoplasty. They are the highest risk for this. They're also the patients who are desiring this because they don't want to go under the knife again for a tiny little change. So they are the highest risk for this. And in my own practice, all of the patients where I've had that complication, a blockage of vessels, has been in post-rhinoplasty patients. We talk about these risks. We took care of these patients. There were no adverse sort of issues relative to these patients because we're always checking for these issues, and we're able to care for them. But there are other providers out there who treat in street, so to speak, right? Like they treat their patients, they're out the door, doors closed, end of day, you can't contact anybody if there's a problem. And really that's sort of the problem with the cosmetic industry to some extent, is you really have to find a provider who's able to take care of you. And like any other procedure, not only do you have to do the procedure well, but more importantly, you have to be able to take care of the complications of that procedure.
That's probably the most, like I would say equally as important as the
Correct.
procedure itself.
Yeah, yeah.
For
And
sure.
just in your specialty, I mean, sinus surgery, every otolaryngologist does sinus surgery. How many of them are able to fix a CSF leak or a really bad bleed from the brain, right? Or a bad bleed in general, orbital complications, et cetera.
Absolutely.
You go to a guy like Sammy who does this every single day. He's doing brain surgery through the nose, and he's the guy to see to fix that particular problem, because you can deal with these complications better than anybody out there.
Yes.
Is really sort of the take home. And that's what you want in a provider doing any procedure for you, is somebody who's going to be able to take care of you in the rare instance that you do have a problem.
Yeah, I 1,000% agree with you. It's like I think I can't remember who or one of the people we've talked to here, but one of the ways that was described is like, you're not just there for the procedure, you're there for the entirety of the journey.
Correct.
And you want to be there. You're going to shepherd them through the journey itself. And I think that's where many colleagues of ours that, they don't always understand that piece. And because of that, they miss out on complications that could have been prevented, or missed on the opportunities to help people in a delayed fashion, or or in an inappropriate fashion, and not be delayed. So I thank you for that. But I very much 100% agree with you with what you're saying.
Yeah,
for sure.
And in general, really sort of the reality is that for a lot of us, and we learn this from our mentors as well, but this isn't just a patient that you're treating with this one isolated problem, right? This is a person who has a problem that's coming to you, and you're creating a relationship that will endure far beyond this individual procedure. And really, we're in the relationship making business. And that, I think, is foremost to providing the best quality care to our patients going forward. We want these people coming back. We want, their family coming back. We're taking care of them like we would their family. And really, that is what provides our patients with the best possible outcomes and allows us to sleep better at night, knowing that we're taking care of them like we would anybody else.
Absolutely. I always liken it to when I talk to my dad, because as you know, he's a clinical psychologist. And the one thing he'd always used to say to me, and I think that's actually very much true for me as well, the number one thing for me, aside from like whatever their outcome is, that's important, but the most important thing is that we have trust. And I don't want to break their trust, and they shouldn't break mine. And so that relationship, I think, if you don't take them on that journey, in some ways you are either neglecting it in some which way, not being the gardener that you're supposed to be, to kind of make sure that the whole process goes towards the end.
At the end, you want the beautiful garden. You want that patient to be happy and to be well taken care of, and to sort of deal with all of their issues if it's possible, right? Like, I mean, within my, partially within yours, I guess in your and my specialties are very similar relative
Very
to
much so.
expectation setting,
Yep.
right? I mean, the patient coming in with chronic sinusitis, you can make them better, but you're probably not going to take away that particular disease in its entirety. Somebody with allergies, whatever, you're not going to be able to take that away in their entirety. It's just managing that problem. Same thing within my specialty, we're managing expectations, and we're really trying to solidify sort of what they'd like, what I can deliver upon, and marrying those two together to create the best possible relationship, as opposed to sort of some discrepancy in there, whether, it's the provider who's over-promising on what they can particularly deliver, or the patient who's over-expectant relative to what they think will come about relative to this procedure.
That's absolutely true. And something we studied a lot for our exams, trying to avoid those people, for sure.
Exactly right.
But all right, so now getting into the technical part of this, because this is a personal interest to me. So what patients would you say, and this is like, say, a person is thinking about, like, I want some alteration to my nasal cavity. I'm not coming in here just for function purposes. I'm coming in here for cosmetic reasons. What makes me not be a candidate for a liquid rhinoplasty?
Great question.
Yeah.
So there's a variety of things, one of which is previous surgery. I mean, that is first and foremost. Previous rhinoplasty surgery makes them a higher risk patient. It's not that we won't do it, but they're a higher risk patient that we really have to counsel and figure out exactly what they want to deliver upon.
Okay.
It's a liquid gel, so I am adding to your overall nose. So if you want to make your nose smaller, it's not happening. If you want to make your nose narrower, It's not going to happen.
Mm-hmm.
The only thing that really non-surgical or the main patient population that this is really for
Mm-hmm.
are patients who are dissatisfied when they look at their nose from a side profile angle. So if they're seeing a bump on the
Mm-hmm.
top of their nose, if they'd like to change the orientation of their nasal tip,
Mm-hmm.
for example, those are things that can be delivered upon. Everything else is a little bit sort of more challenging and higher risk relative to working with asymmetries or all these sort of subtle features or features that you're seeing when you're looking straight on. It's really for huge changes from the profile perspective.
Because I was noticing, I think one of our colleagues, I can't remember who it was now at the top of my head, had posted some of their before and after pictures of doing this with this technique. And they did show the side profile, and the person had a dorsal hump. And when I saw it, I was like, "Oh, this just seems standard, like you do a normal septal rhinoplasty." And they said, "No, this is purely non-surgical liquid." I was like, "Wow, how do they achieve? How would someone achieve that with a dorsal hump that traditionally was like a slam dunk, that this is what you'd go in and just take this piece off?"
Yeah. It's a great question. Check out my Instagram. You can see a lot of these. It's really cool. DRM Brandt. Yeah. But aside from that,
please do. I highly recommend it. He's worthwhile following. They're actually, some of his Instagram stuff is really quite funny too. So you guys would enjoy.
We try to keep people entertained. But relative to rhinoplasty specifically, so what we do in the situation of having a dorsal hump or a bump on the top of their nose is we typically fill behind it and in front of it, for example. So we'll fill within this crevice as long as they have a forehead that will allow us to do that, in the sense that we don't want to avatar people's noses. We don't want to connect their forehead to their nose. It looks bizarre. So we won't do that, but we will fill behind the bump to smooth it out on top. We can fill in front of the bump a little bit to smooth it out, but you'd be surprised how many patients, once you treat it behind, how much smoother it looks. And then if we start doing some refinement relative to the tip of their nose, sometimes you don't even have to treat the area in front, because the tip will come up and give them a little bit more of that smooth profile that they're after. It's sort of, as I said, it's magical surgery. It is, a magical procedure. It's spectacular what can be achieved. Some patients do better than others, and it's still a bit of a learning sort of curve relative to deciding on the best patients. Patients with thicker skin, just like in your rhinoplasty patients, you need to get more effort under that skin to really see any changes underneath that thick duvet, right? You have that thick duvet, you're trying to build it up. You're not going to see the refinement that you would in somebody with a thin blanket for skin over top. But, there's in general, there's usually something we can offer most patients.
Interesting. Wow.
Yeah.
So, because just the concepts of adding more volume to something that you think you're supposed to take away volume for is kind of counterintuitive.
I know, right?
But it definitely, I've seen the results, and they do work. So it's almost like you're playing with both your mind's eye of interpretation of what the face is doing, and then also the physics of what you have to do to kind of maintain those facial angles that you're doing.
Right. And that's part of, your training, my training within facial plastics, and every otolaryngologist goes through some sort of degree of facial plastic education, right?
Yeah.
Certainly our colleagues within plastic surgery recognize this as well. I mean, the nose serves multiple purposes, of course. There's the functional purposes and all that. But from an aesthetic perspective, the nose is a distraction to the eyes, really, at the end of the day. It's about balance and harmony. So if you can eliminate that distraction from looking in someone's eyes, and have that nose sort of blend into the background, you've achieved success relative to your rhinoplasty. And the same is true of non-surgical rhinoplasty.
That's actually a great way to describe it. That's the first, I haven't heard anyone say it that way, but yes, it is a distraction to your eyes, because if something's off, it's the first place your mind goes.
Yeah. Look at Owen Wilson, right? I mean, he carries it well, but you can't help but stare at the man's nose, right? I mean, that's his defining feature. He uses it. He loves it. It's great.
And a fantastic actor. If you ever watch this, fantastic actor.
Yeah. But he's a case in point, right? It is so distracting. I mean, he's got a lot of asymmetries to his eyes and other things, but you don't really look at that because you're just so focused at looking at his nose. Right? Yeah. It's just one of those sort of features. And if it melts into the background, you've done a great job.
Wow.
Yeah.
And so now you inject the gels. Talk to us a little bit about, you've already mentioned a little bit about the complications. What can people do, or clinicians like myself, what would they do to kind of minimize those risks?
spend time with someone like me, and we can go through that. There are education courses and stuff. I teach with a group called CBAM, Canadian Board of Aesthetic Medicine. We teach some of these techniques through, live demos as well as workshops where people get to come in and try some of these techniques themselves on real patients with my supervision. Like being a resident, we're right there. We're right in on it.
Yep.
If the results aren't as good as I did it, then they don't get to do it at all. Is really sort of the way it works. But that's probably the best way. You can read some of the literature, of course, and sort of get a general idea of what's involved. And there, basically, you with treating with fillers around the nose, staying in the midline, injecting with low pressure, low volume augmentation is really sort of the way to go to try to achieve the best possible outcome while mitigating some of these risks.
That's awesome. All right. Well, great advice for sure. Yeah. I know one other thing that you wanted to kind of we chatted a little about was the new advent that people getting deep plane lifts. Now, which is funny because when you brought it up, I was like, is it really that new? And you asked the same question. I was like, because I remember being given by Corey Moore, who's by the way, phenomenal person. If you ever get the chance to meet him in London, Ontario, great guy. He's one of our facial plastics mentors, and he was our program director at the time. I was tasked with our grand rounds, and my grand rounds was all on facelifts. And I remember having a whole section on deep plane lifts and who to use them for and all that kind of stuff. And I thought it was just something part of the algorithm of what people do, but it sounds like it's having some surgeons in the people actually doing it. Is that what's happening?
Yeah, it's having a new renaissance, right? Is if you're not doing deep plane facelifts, are you really doing facelifts, right? So it's certainly going through its moment right now where there are some spectacular surgeons worldwide who are really sort of pushing the deep plane facelift and sort of, using it in all of their patients. I see each one of these sort of lifts or strategies as a tool, really, in the grand scheme of things. I mean, within the sinus space, does everybody need their frontal sinuses open? Probably not.
Nope.
I mean, but same thing with a deep plane facelift. Not everybody requires the full deep plane. Does it work for most patients? Yes, absolutely. Is it without risk? No, there's some slightly added risks to doing that. Same thing, we're taking out a lot of partial submandibular glands through, a neck lift incision these days. Does everybody need that? No, but in the right patient, it can be very impactful. And the same thing with a deep plane. So the deep plane technique, as you just mentioned, it's been around for a very, very long time. It's nothing relatively new. Yes, there are some nuances that have changed and design and strategies that have changed relative to how it's done and how it's secured after you sort of elevate the tissues. Because really in a facelift, what we're doing, obviously, you've got the skin and you've got the deeper structures underneath, right? So what we're trying to do is lift some of that deeper foundational structure to really restore things without just pulling on the skin. Because if you just pull on the skin, it eventually fails.
I guess for the audience, they can know that when we talk about facelift surgery, it's usually defined, correct me if I'm wrong, in the four subproducts, or is it three? I can't recall. Super SMAS, sub SMAS, and then the deep plane. Is that correct?
Yeah. Yeah, that's about right.
Yeah, I think if I remember what all that stuff.
Well done. It's been a while, right?
So what that means for people who don't know, the SMAS is the group of facial muscles that help control our face. We label it that way because rather than individually naming out every single muscle, because there's a lot of them, so we can do a facelift just on the skin, right?
Correct.
And then we can do it below the skin, including the muscles of the skin as well, but still above the level of where we have the facial nerve, the one that controls your face. And then the deep plane, well, I'll let you say what that includes. As
you described, the skin only sort of facelift really has sort of gone out of popularity because it fails very quickly.
Right.
And you get stretching of the skin and scar and all this other stuff. So we don't really do that anymore. Beyond the skin only lift, you have to do something with this muscular layer called the SMAS. So the SMAS, as you mentioned, is all the muscles of the face, including down into the neck, the platysma muscle, the one we tense when we're shaving, this guy. So all those muscles are enveloped by effectively saran wrap or fascia.
Right.
So what we can do is we can manipulate that layer either by sewing to itself. So that's called a plication lift, where we're sort of taking the SMAS, we're lifting it up, we're folding it on itself and sewing so that it scars down in that new location. Or we're making an incision within that SMAS, going underneath that SMAS, traveling along some of these muscles of the face, where technically the facial nerve lives. And we can either go sort of just a little bit, which is sort of a sub-SMAS dissection, or a deep plane where we're really sort of extending that dissection forward and we're really releasing all the ligaments of the face, which sort of tether all those layers down, releasing all those, and then repositioning that tissue and sewing it down to create that structural change. And then later we're sort of tailoring the skin to that structural change. And that gives us a facelift that endures and lasts for a lot longer than doing anything just on the skin surface.
So that's kind of the technique for what it is we're talking about. And so what I remember from before, and again, this has been a while since I've had to do a facelift, but what I remember from before is that typically we use the deep plane facelifts for people who had a lot more jowling. Is that correct?
Yeah, so it's still for jowling without question.
And jowling is when I guess, I don't know how the best way to describe it.
Yeah, so it's like this guy comes forward.
Yeah.
You start getting this sort of, you know,
looping.
resting sort of skin and tissue right over here by your chin. Yes, it's great for jowls. Most facelifts can help with that too. It also helps a lot with these guys, the nasolabial folds,
right?
Because they're really able to push them back. Now, there's a variety of ways of improving each one of these things. And the deep plane is simply, as I said at the outset, it is a tool within the toolbox that can be deployed by the right surgeon in the right circumstance to really achieve the best results. And within my practice, certainly I use it. It's not the only technique that I use, though. Yeah.
So now, looking at all these things and everything else you said, you mentioned that you really enjoy doing the liquid rhinoplasties. What is your favorite thing that you do of all the stuff that you do, besides hanging out with your family, of course?
Obviously, hanging out with family is paramount. But, you know, aside from that, I love, you know, all the aesthetic stuff relative to the liquid rhinoplasty and the hair transplantation and facial rejuvenation, you know, setting patients back years and decades, making them feel more confident, making them feel better, you know, whether that's eyelid surgery or facelift surgery or neck stuff. And then there's still sort of skin cancer reconstruction and fixing holes, so to speak. They've got a skin cancer. They didn't want that skin cancer. They end up having it. They end up being devastated with this hole on their skin in their middle of their face. And I got to come up with a creative way of fixing that. And as far as sort of the mental component and my original love for facial plastic surgery, that's first and foremost. You know, that's what got me into it, got me being like, that is the coolest thing ever, how you can close that without creating a ton of scars on the face and restoring that person back to normal life where nobody notices that they've had this sort of stuff done. That's what got me into it. That's what continues to sort of drive my sort of creative juices, so to speak, relative to making these patients better.
Well, and it shows, buddy. I definitely, I can see that for sure. That's awesome.
Yeah.
I'm going to preface this first that I know you're not a dermatologist. That's not what the reason why I'm asking the question. But in this whole process of all the care you take for people, for aging, their skin, all these things, is there, for a general person in the public who might be watching this, saying, what would be a couple of things that, like, you would say to them that they can do to help preserve their face and their hair or these types of things before they would have to come and see you?
Right. So, you know, there are some basics. I mean, the basics are similar to the basics of general sort of health, right? So eat well, sleep well, try to reduce some stress in your life if possible. You know, all of those sort of factors play in, right? But aside from those things, I mean, the three main cores to skin quality, skin care are really sort of moisturization, keeping your skin moist, especially harsh winter weather, all of that. So using a good quality moisturizer, some form of UV protection is critical to preventing the number one cause of skin cancer, the sun, and also number one cause of aging is the sun, right? So if you can prevent that with, you know, using a good quality skincare product sunscreen, you're ahead of the game, far and away. The final one is increasing cell turnover. Okay. So if we can speed that along, it can really restore your skin and thicken things and build collagen. How do we do that? Those are the retinols. Okay. So the retinol medications do photosensitize you a little bit, meaning you're more susceptible to sunburns and all that. So you have to use UV protection when you're on them. You can't use them during sort of periods of life where you're considering having children. You got to be careful with it then as well. But as far as like the three pillars of sort of aesthetic dermatology skin, it's really retinols, sunscreen, and moisturizer. Okay. Everything else is great and fun, but those are the three cores.
All right. Yeah. Retinol, sunscreen, moisturizer. I'll remember that.
Yeah.
Now, this is a question for people like us at a younger stage.
I'm glad you called me younger.
That's right. If you're, let's say, a young med student or an undergrad student who's thinking about going into this career and they don't have a clue where to start, what would you recommend as a guiding step or somewhere to begin or how to get connected to say, like, hey, is this a pathway I'd like to go?
Yeah, I think, in general, as probably similar to your experience, my experience, finding a great mentor is helpful along the way across the board. If you compare that mentor with a discipline that you really enjoy, even better, right? As we get to the stage where we're at now, we look back, we're like, were there things we could have changed or done differently? Sure, there's lots of different things. But, those are sort of the cores, is finding a great mentor who can sort of guide you and help you along along that pathway, and then spending some time within the discipline and seeing what you like and what you dislike about it, right? The real question I pose to a lot of sort of the students that come in and train, within otolaryngology, like when you were a med student and beyond, is, look for the part of the specialty, not that you love. Look at the part of the specialty that drives you crazy or that you don't like doing. And imagine doing that 8 hours a day, 5 days a week. And if that is something that you can't stomach, that's not the right specialty for you. Is really sort of the take home. Within our specialty, there's a variety of different things within that space.
That's right.
That we'd rather, maybe not do, but, it's part of the game, and we get to do great things beyond that within our space that sort of supersede some of those issues. But that's usually the advice I tell people.
Yeah, I think that's great advice. It's about finding balance. You can't get everything perfect in whatever you choose. But the one that is the least, the annoying part is the least annoying to you.
Exactly.
That's probably the right one.
Yeah. Without question, right?
Yeah.
And part of it is also sort of, obviously, the first crux point that I tell most med students is deciding sort of between medicine and surgery, so to speak. Are you more of a surgical personality or a medical personality? Do you like doing things with your hands? Are you afraid of blood? Or, what sort of, what's your technicality at? Can you do things? If you really like that part, if you like sort of a physical intervention to a physical problem, surgery is your go-to. There is no better thing in the world than being able to make an intervention. There is a cancer. I'm going to cut it out. I'm going to cure that. That's going to make me feel great. It's going to make my patient happy. Life is great. Alternatively, medicine, right? Like if you like dealing with really complex problems and problem solving, and you're really a sleuth for finding a solution and trying different ways of fixing that solution, then, that could be medicine for you. And then there's a variety of specialties that sort of carry a little bit of both, right? Like emergency medicine and anesthesia and these other areas where there's some procedural stuff as well. And once you've sort of determined some of those pathways, and you also want to balance quality of life and all these other factors that play in. And then it's also about picking a part of the body that you really sort of want to deal with all the time. Right?
No, I know, because when I was going through, people would all equate a lot of similarities between ENT and urology. And you'd say to yourself, how is that possible? Right? Because the two don't have the same, but the practice of them are similar.
Yes.
Right? In the sense that, you have procedures, you have medicine, you have a relatively good work-life balance with things. But to your point, I didn't want to be down in the pelvis. I don't know about you.
Correct. Yeah, it's well below the clavicle.
That's right.
Wasn't exactly sort of my idea of a great time.
No, I would agree.
But, for other people, whatever floats their boat, right? I'm so happy that there are specialists who love taking care of those particular problems.
Yeah.
I've had personal interaction where I needed that particular, that particular specialty. And I certainly appreciated that they were great at their job.
Absolutely. And you look fantastic, by the way. Just so you
you're
know.
a good man.
Just so you know.
Yeah.
You're keeping up with the name, the form, face, and body.
That's it.
Well, Mike, it's been fantastic having you here. I cannot thank you enough for coming to visit. Next time, I would love to have you here, talk about whatever you want, or we sit and just reminisce, whatever you'd want.
That'd be great. Thank you so much, Sammy.
It's been so awesome having you here.
Yeah. Thank you for having me. It's been a pleasure. Congrats on the podcast.
Well, thank you so much.
Well, that wraps up today's episode. I just wanted to say a huge thank you to everyone who's followed us into Season 2 from Season 1. Your support truly means so much. And if this is your first episode that you're tuning into, welcome. As always, please make sure you follow us on our socials and, most importantly, leaving us a comment. We would love to hear back from you. Whether you're listening to us or watching us, I hope you have a fantastic day. Ciao.